Hey everyone, it's Nurse Lou. Welcome to the most important hour of your pre-nursing career. The National Council Licensure Examination, the dreaded NCLEX, feels like this enormous, terrifying mountain you have to climb. It stands between you and your dream. But climbing this mountain isn't just about memorizing every fact. It's about strategy. The NCLEX isn't trying to trick you. It's trying to make sure you are a safe and effective nurse. That's the bottom line. In this review, we're going to cut through the noise. We'll use the step-by-step mastery method, focusing on the high-yield, critical concepts that show up again and again. So take a deep breath, let go of that anxiety. For the next 20 minutes, it's just you and me. The climb starts now. When you're faced with a complex patient case, where do you begin? You start with your first clue, the laboratory values. These numbers are the objective truth, the hard data that cuts through the noise and tells you exactly what's happening inside your patient's body. Knowing the normal ranges is step one, but truly understanding them transforms you from a student into a skilled clinician. Let's lock in these normals with memory hacks that will stick with you. First up, potassium. The normal range is 3.5 to 5.0. Potassium is a powerhouse electrolyte critical for nerve impulses and muscle contraction, especially the most important muscle of all, the heart. To remember its range, think bananas. You typically buy them in bunches of 3 to 5. Any deviation here can cause serious cardiac issues, so this is a number you always watch closely. Next, let's talk about sodium, the king of fluid balance. Its normal range is 135 to 145. An easy way to remember this is that it's odd to have a value between 135 and 145. Sodium is the primary driver of hydration status and blood pressure. Remember the phrase, where sodium goes, water flows. Imbalances can lead to major neurological problems like confusion and seizures, so this range is vital. Now for chloride, 95 to 105. Chloride is sodium's best friend. They often move together to maintain that delicate fluid balance. It's also a key component of stomach acid. To remember its range, think of a chlorinated pool on a hot summer day. The perfect water temperature is 95 to 105 degrees. Let's check on the kidneys with BUN and creatinine. BUN, or blood urea nitrogen, should be between 10 and 20. Think of buying a hamburger on a bun for $10 to $20. Creatinine, a more specific marker for kidney function, has a much smaller range, 0.6 to 1.2. High levels of either, especially creatinine, suggest the kidneys aren't filtering waste effectively, a condition you need to address quickly. And what about calcium? Its range is 9 to 11. Just remember to call 911. Calcium is essential for strong bones, blood clotting, and muscle contractions. If it's too low, you'll see signs of neuromuscular excitability like Chavostex and Trousseau signs. Finally, magnesium's range is 1.5 to 2.5. Think of a magnifying glass that makes things 1.5 to 2.5 times bigger. Magnesium is a relaxant for the muscles, a true mellowing agent for the body. Now for the oh crap labs. These critical values mean you stop everything and act immediately. An easy way to remember the most life-threatening values is the rule of sixes. First, a pH in the sixes. A normal pH is 7.35 to 7.45. A pH in the sixes means the patient is severely acidotic. Every cellular process is failing. This patient is your top priority. Also in the rule of sixes, potassium over 6. This is a massive risk for lethal cardiac dysrhythmias. You'll see peaked T waves on the EKG, a prelude to ventricular fibrillation. Next, CO2 over 60 or O2 under 60. This is the 60-60 club for respiratory failure. The patient is either retaining too much acidic CO2 or not getting enough oxygen. Both paths lead to collapse. And one more, platelets below 40,000. This patient is at high risk for a spontaneous fatal bleed. Speaking of critical lows, let's discuss neutropenia. When a patient's white blood cell count is less than 1,000, or more specifically, their absolute neutrophil count, or ANC, is less than 500, they have virtually no defense against infection. They need neutropenic precautions. This isn't just a suggestion, it's a lifeline. It means strict obsessive hand hygiene. It means a private room and absolutely no fresh flowers, fruits or vegetables, as they can harbor deadly bacteria and fungi. Visitors must be limited and screened for any illness. All equipment is dedicated to that room. In this scenario, you are their entire immune system. Your diligence is their only defense. Finally, let's demystify arterial blood gases, or ABGs. Think of it as a balancing act. The pH, which should be between 7.35 and 7.45, is the ultimate goal. It's balanced by two systems: the respiratory system, represented by PaCO2, and the metabolic system, represented by bicarbonate, or HCO3. The lungs control CO2, an acid with a normal range of 35 to 45. The kidneys control bicarbonate, a base with a normal range of 22 to 26. To interpret ABGs, remember the Rome mnemonic: respiratory opposite, metabolic equal. Let's break it down. If the pH is low, indicating acidosis, and the PaCO2 is high, moving in the opposite direction, it's respiratory acidosis, often from hypoventilation. If the pH is high, for alkalosis, and the PaCO2 is low, again opposite, it's respiratory alkalosis from hyperventilation. Now for metabolic. If the pH is low and the HCO3 is also low, moving in the same or equal direction, it's metabolic acidosis, seen in DKA, severe diarrhea, or renal failure. If the pH is high and HCO3 is also high, again equal, it's metabolic alkalosis, often from severe vomiting. This simple mnemonic is your key to unlocking ABGs. Let's move to Act 2, safety. In healthcare, safety is the bedrock of everything we do, protecting both patients and providers. Mastering infection control is a critical, non-negotiable component of this. Before we even discuss specific isolation types, remember the foundation: standard precautions. This is the minimum level of infection control used for all patients, regardless of their diagnosis. It's centered on meticulous hand hygiene and using personal protective equipment, or PPE, when anticipating contact with bodily fluids. On top of this, we layer transmission-based precautions. Think of these as different security levels tailored to how a specific pathogen spreads. First is contact precautions for germs spread by direct or indirect touch, like MRSA or C. diff. This requires a gown and gloves before entering the room. All equipment used for the patient should be disposable or dedicated specifically to them to prevent cross-contamination. Next is droplet precautions for pathogens spread through larger respiratory droplets from a cough, sneeze, or talking, like influenza or pertussis. This requires a surgical mask when you're within 3 to 6 feet of the patient. If the patient has to leave the room, they should wear a surgical mask as well. And finally, airborne precautions. This is for tiny aerosolized particles that can hang in the air for extended periods, like with tuberculosis, measles, or varicella. This is the highest level of respiratory protection, requiring a private negative pressure room to contain the air and a personally fitted N95 respirator for anyone entering the room. Putting on PPE, donning, is straightforward, but taking it off, doffing, is where the real danger lies. The outside of your PPE is now considered contaminated, and a single misstep can lead to self-contamination. The easiest way to remember the correct sequence is to go in alphabetical order. This simple mnemonic is your key to a safe exit. First, gloves. They are the most contaminated items. Remove them carefully, peeling one off with the other. Next, goggles or your face shield. Remove from the back by lifting the strap over your head. Then the gown. Untie it and carefully peel it away from your body, turning it inside out as you roll it into a bundle. Finally, the mask or N95 respirator. This is removed last, ideally after you've left the patient's room. Grasp the elastics and pull it away from your face without touching the front. Gloves, goggles, gown, then mask. It's an alphabetical escape plan that will keep you safe every time. And the final crucial step after any PPE removal, meticulous hand hygiene. Now let's shift to mobility. For patients using assistive devices, our primary goals are to maximize their independence while ensuring their safety and preventing falls. This starts with proper fitting. For crutches, safety is key. There must be a 2 to 3 finger breadth gap below the armpit or axilla. Critically, the patient's weight should be on their hands and arms, not resting on the armpits. This prevents nerve damage to the brachial plexus. Also check for a 15 to 30 degree bend at the elbow when their hand is on the grip. Once fitted, teach the correct gait. For a patient who cannot bear weight on one leg, we use a 3-point gait. Move both crutches and the affected leg forward together, then swing the strong leg through. For navigating stairs, the mnemonic is simple and effective. Up with the good, down with the bad. When going up, the patient should step up with their good, unaffected leg first, then bring the crutches and the bad leg up to the same step. The strong leg provides the power. When going down, they lead with the bad leg and the crutches first, then bring the good leg down. For canes, remember the acronym COAL, cane opposite affected leg. The patient should hold the cane on their strong or unaffected side. This widens their base of support and helps shift weight off the weaker leg. They should advance the cane, then the weak leg, then the strong leg. For patients needing even more stability, we use a walker. Instruct them to lift or roll the walker a short distance forward and then step the frame, keeping all 4 points of the walker on the ground as they move. They should never try to climb stairs with a walker. Finally, a word on restraints. These are an absolute last resort, used only to ensure the immediate physical safety of the patient or others when no less restrictive alternative is effective. Alternatives like reorientation, diversion, or moving the patient closer to the nurse's station must be tried and documented first. You must have a provider's order that is time limited and specifies the reason and type of restraint. It can never be a PRN or as needed order. When a restraint is in place, your monitoring must be constant and thorough. Check circulation by assessing pulses, colour, and capillary refill distal to the device every 15 to 30 minutes initially, then typically every 2 hours. Assess skin integrity for any signs of breakdown. Offer fluids, nutrition, and toileting regularly, and always use a quick release knot tied to a non-movable part of the bed frame, never the side rails which move up and down. Act 3, diabetes. You must know the difference between type 1 and type 2. For type 1, remember the letter K. Type 1 is for kids. They are prone to ketosis and they must keep insulin nearby to survive. They make no insulin at all. Their big emergency is DKA or diabetic ketoacidosis. Remember the DKA mnemonic: dehydration, ketones, cuspal breathing, and acidosis. The opposite emergency is hypoglycemia or low blood sugar. If they're awake and can swallow, give them juice or candy. If they're unconscious, give a glucagon injection or IV dextrose. Let's dive into high-yield pharmacology, starting with insulin. Knowing insulin peaks is vital, as that's when the risk for hypoglycemia is highest. Rapid-acting insulins like Lispro peak in about 1 hour. This is your mealtime insulin, so make sure food is ready. Short-acting or regular insulin is the only one for IV use. It peaks in 2 to 4 hours. Intermediate-acting NPH is cloudy and peaks broadly from 4 to 12 hours. And long-acting insulins, like glargine, have no peak, providing steady basal coverage. If your patient becomes hypoglycemic, cool and clammy, use the 15 to 15 rule. Give 15 grams of simple carbs, like 4 ounces of juice, and recheck their blood sugar in 15 minutes. Now, let's head to the maternity ward. For pregnancy confirmation, know the difference between presumptive, probable, and positive signs. Presumptive signs are subjective things the patient reports, like nausea or amenorrhea. Probable signs are objective findings by a provider, like a positive HCG test. But only 3 signs are 100% positive because they confirm a fetus. 1. Visualizing the fetus on an ultrasound. 2. Hearing fetal heart sounds with a Doppler. And 3. The provider palpating fetal movement. Remember, if the provider can see it, hear it, or feel it, it's positive. Assessing fetal growth involves measuring fundal height. The key landmark is at 20 to 22 weeks, when the fundus is at the umbilicus. After 20 weeks, the fundal height in centimeters should roughly match the weeks of gestation, plus or minus 2. For example, a 30-week patient should measure 28 to 32 centimeters. Significant deviations could indicate issues like multiple fetuses or growth restriction. During labor, we use the mnemonic VEAL CHOP to interpret fetal heart rate patterns. V is for variable decelerations caused by C cord compression. They look like sharp V-shaped dips. E is for early decelerations caused by H head compression. These mirror contractions and are normal. A is for accelerations, which means, oh, it's okay. The fetus is well oxygenated. L is for late decelerations caused by P, placental insufficiency. These are the most worrisome as they signal the fetus isn't getting enough oxygen. For worrisome patterns like late decelerations, act immediately with the Lyon's mnemonic. L. Turn the patient to her left side to improve blood flow. I. Increase IV fluids to boost volume. O. Apply oxygen via a non-rebreather mask. N. Notify the provider. And S. Stop any Pitocin infusion as it can worsen the problem. Remember, Lyons, left side, IV fluids, oxygen, notify, and stop Pitocin. Now, for a rapid-fire review of drugs with narrow therapeutic ranges. First, lithium, its range is 0.6 to 1.2. Toxicity above 1.5 causes coarse tremors. Next, digoxin with a range of 0.5 to 2.0. Toxicity above 2 can cause bradycardia and vision changes like yellow-green halos. Always check the apical pulse before giving. Finally, theophylline and phenytoin both have a therapeutic range of 10 to 20. Above 20 is toxic. Risking seizures with theophylline or ataxia with phenytoin. You must know your antidotes. For warfarin, the antidote is vitamin K. For heparin, it's protamine sulfate. For an opioid overdose, it's naloxone. For benzodiazepines, it's flumazenil. And for magnesium sulfate toxicity, which you'll see in OB, the antidote is calcium gluconate. You'll spot MAG toxicity by a loss of deep tendon reflexes. Finally, let's cover aminoglycosides, the mean old mycins like gentamicin. To remember their toxicity, think of a mouse, since mycin sounds like mice. The big ears remind you of ototoxicity, so monitor for tinnitus. The kidney-shaped body reminds you of nephrotoxicity, so monitor creatinine. A rising creatinine is a red flag. Because they're so toxic, we must monitor peak and trough levels. The trough is drawn right before a dose to check for clearance, and the peak is drawn after the dose to ensure it's therapeutic. Welcome to the final act, delegation and prioritization. This is the final boss of the NCLEX. As the RN, you can never delegate assessment, teaching, or evaluation. Remember the acronym ATE. These tasks belong to you. A simple rule: an RN should never delegate the first of anything. The first assessment, the first dose of a new IV med, or the first time a patient gets out of bed after surgery. When prioritizing, always see the most unstable patient first. Ask yourself, is it an acute or chronic problem, an expected or unexpected finding? Look for the red flags. A sudden change in level of consciousness, new onset chest pain, or anything involving the ABCs, airway, breathing, and circulation. We've made it to the summit. This exam is not the finish line, it is the starting gate. The habits you build to pass this exam will be the foundation of your entire nursing practice. It's about becoming the nurse your patients deserve. The real test begins now. You have the knowledge, the strategy, and the heart to succeed. Trust your training, trust your clinical judgment. Go out there, pass that exam, and start your incredible journey. I am so proud of you, and I can't wait to call you a colleague. You've got this.